Take it away, Kari.
I'm working on it. I'm trying. I'm not as, I want to make sure I pull up the correct PowerPoint, that's all. You're more technologically sound than I am.
Not really.
Okay, I think I have it up there. Is that right?
Yes, we can see your screen.
We can see.
Okay, so thank you to, so Amy or Abby and I tried to put together some meaningful slides for you as far as our year in review, and we'll also include just a little bit of history as well. So as everybody knows, we continue to outrank the United States in most of the vascular risk factors based on the most recent data that we have, which is BRFIS. I'll call your attention to the high blood pressure prevalence, because we all know it's #1 risk factor for stroke. When you look at the CDC map that was in the EMS presentation, we know that we sit in the stroke belt, and then in the vital signs report from CDC in 2018, at least we can look at it and say, well, Kentucky has slowed or decreased the death rate over time. And, you know, while most of us, some of us have been doing this for a very long time, you know, when we started in this in Kentucky as well as the US, stroke was the 3rd leading cause of death. And then it was the 4th leading cause of death. And now it's the 5th leading cause of death. So I think that just indicates that we are delivering better care on the acute stroke therapies, but we have maybe opportunity to increase our work on the prevention side of things. Recent data also looking at the Medicare data from the CDC Atlas, where you can generate some maps. So if we just look at by county, and of course the darker areas are the heaviest incidents for the Medicare population. Most recent data is from 2015 to 2017. You can sort of see how do we rank by ischemic stroke hospitalizations by county. Then out of the ischemic strokes, how many of them, what was the likelihood by county that you would be discharged home compared to death during your inpatient hospitalization for your stroke. And then I added this because this was new to me, and we were looking at this for the what would be meaningful for the EMS talk, and that's how I sort of stumbled on this, and we elected not to include it. But gosh, look at the non-adherence to antihypertensive medication and the risk of ischemic strokes. And the dark areas line up pretty much with the highest areas of having an ischemic stroke to begin with. So just something I think that's probably eye-opening. The biggest bang for our buck is probably on high blood pressure, and you know, a pitch for the Department for Public Health's Care Collaborative, which I know a lot of facilities in SEQIP are working to incorporate, as well as the healthcare systems, looking at how they can get that Know Your Numbers campaign entered into their prevention side of things. So we've seen this, just to review for the new members. I'm going to go over that in detail in just a second. The strategic map and plan has been put forth. And of course, SEQIP falls here under the maintain and continue to improve the statewide cerebrovascular systems of care. Again, our structure is such that we have the steering committee that provides oversight to the entire membership, and then we have subcommittees working on these specific efforts with chairs that lead those initiatives with many of you as members. And if you are new and would like to join one of these groups, please reach out. You're going to have an opportunity to hear from the chairs later on today, and there's ample opportunity for anybody to become involved that would like to be involved, and we welcome your input. So this is very nicely done synopsis of where we've been, and how we've gotten there. And STAR put this together at the end of last year, and it sort of expanded. And here in 2008, you can see SEQIP. This is when SEQIP was sort of thought about. This is a collaboration between American Heart, American Stroke, the Heart Disease and Stroke Prevention Program. And at that time, a group of geographically targeted hospitals that were either currently stroke center certified or working towards stroke center certification were identified and agreed to participate in the membership. And the inaugural meeting was held in 2009. Bonita likes to talk about how it was famously held in the middle of an ice storm, and all hospitals showed up except for one. And the only reason that they couldn't show up was because it was the worst ice storm we've ever had, and they were feeding the community, literally taking care of a disaster in their area out in Paducah. Otherwise, you know, they would have been there as well. In 2010, as a reminder, there was the passage of Senate Bill 1 defining primary stroke center certification, and essentially saying that if you weren't designated as or certified as a stroke center, then you could not advertise yourself as such. At this time, we had worked on the dysphagia intervention to improve swallowing evaluation before oral intake, and then in 2010 began to, while working on the dysphagia, continuing those efforts, adding in addressing eligibility and administration of IV Alteplase. And you can see here, and we'll review the data in just a little bit with improvements in door to needle times over time. Looking at incorporating the Target Stroke Initiative in 2011, improving systems of care delivery with rural and critical access hospitals by partnering with the Kentucky Hospital Association to develop education and resources to appropriate personnel. In 2012, additional legislation with House Bill 467 that advocated for continuous quality improvement to provide statewide systems, stroke response and treatment, including a stroke registry for primary stroke certified centers. And this is something that has been a bit of a, well, how do we incorporate this? And we'll talk about it into 2015. But in 2013, the Kentucky Cardiac and Stroke Board of EMS Subcommittee was begun, and members of SEQIP sat on this committee and have currently sit on this committee. And of course, you know, Lacey is the vice chair or the vice president of the organization and helps lead that initiative for us very well. Also, and then in 2014, the interfacility transport protocol was created within K-beams and disseminated for review. Then, sorry, I have to keep moving. I see you guys away from my slide in a different part of the chart. Then in 2015, so this brings up a question that Bonita has, looking to the Department for Public Health for clarification on, as we were generating the report this year, and as we've had different levels of certification come about as far as acute stroke ready, thrombectomy, and comprehensive over the years. So in 2015, the definition of primary stroke center was amended to acute stroke ready, primary, and comprehensive. And it also addresses the need to have EMS stroke protocols. The question here, though, is in the original bill, it stated that primary stroke centers have to submit their data to the Department for Public Health. So the question then is, how do we go about accurately reporting by legislation? All the hospitals are volunteering to approve, but we still have some that are certified that do not. So this is something that she's seeking clarification on, because as SEQIP leaders and as the steering committee was trying to make sure the report was as accurate as it could be, this is something that we're not clear on. Is it by legislation required for acute stroke ready? And all comprehensive stroke centers are submitting their data, but does that law then apply with the name change, or would it need to be a separate piece of legislation? Of course, our first abstracts in 2016 were presented, door to needle times as well as dysphagia at the International Stroke Conference, and the webinars were continued with partnership from the Kentucky Hospital Association. In 2017, we had revised recommended K-beam stroke transport protocols to include CSTAT, launched the quality improvement plan for increasing Alteplase utilization rates in the 3 to 4.5 hour time window, and then incorporated bi-monthly data abstraction calls, and the SEQIP charter was revised and released to everyone for guidelines on how the committees and the SEQIP are structured. In 2018, we had interfacility transfer guidelines posted. The stroke pre-notification algorithm that Lacey showed you earlier was created, albeit hard to find. So if anybody needs that, just let us know. I think, Lacey, you have a copy that you could disseminate if needed. And then a stroke systems gap analysis for our HDSP plan was performed to help us move forward with the creation of the current iteration for 2020 to 2023. And the continuum of care webinars were expanded regionally. Then in 2019, the standardized public messaging awareness group was formed. The Q-Core poster presented for GIS mapping at an AHA conference. K-Beams has finalized 18 data points that they are now collecting and working to report on. The Door In, Door Out committee established an action plan, which has been disseminated and revised and updated over time. A lot of work has been done on stroke survivor community resources, development and dissemination, and a leadership org chart. So 2020, where are we at this year? Well, up till February, things were moving along very nicely and all was working well, and the plan was rolling right along. So we were able to present our abstract of our 10-year experience, looking at all of the stroke core measures as well as outcomes, and present that as an oral abstract at the International Stroke Conference. The pilot program was developed in 2019 and is now being implemented, as you heard Lacey share earlier. Pediatric stroke subcommittee was identified a need, and it conceptually has been formed, but we have not yet moved forward on this due to various reasons. And then the SEQIP webinars really are now regionally as opposed to locally, et cetera. And then so 2021 and 2022. Well, our hope today is to begin some of those discussions to define efforts of where the group would like to go and what we would like to see come out of the next 2 to 3 years. This is the piece of legislation, one of them that I referenced earlier, and it also allows for a report to be sent to the governor annually, which we have been doing. Here you see the 2020 cover of the report, and the purpose of this report was to cover the burden of cardiovascular diseases in Kentucky, also provide an overview of SEQIP, because as you know, so this report, the legislation was approved in 2012, and so subsequent years, we provide a report of our data with background, et cetera, because the members of the cabinet change, either within the same party, different people are appointed, or we might have a change in who the elected official is with different appointees put forward. So the awareness or knowledge base or background we felt was really important to include all of that information. So it has full graphics to include performance measure results for the most current available data, and then also recommendations from the team about how we're moving forward to improve stroke systems of care. So an update on where this plan is currently, and Bonita, if you'd like to chime in here, please do. So as all of you know, our data is frustratingly a year behind. So this is a 2018 data for a 2020 report, and that's due, of course, due to the timeline of having the report submitted for approval through the cabinet, as well as all the layers from the Department for Public Health. And the fact that, when you close out the calendar year, right, it takes 45 days at a minimum to sort of abstract the last quarter of the prior year or the month of December. So turning that around and getting everything to Bonita and her team, we don't have the data through a full year to be able to use through 2019. So that's been a little problematic. It's been difficult every year to sort of think back, like, well, where were we 2 years ago? How were we doing this? What were the numbers? And this year, this report has gone through without a lot of recommendations for change or suggestion other than typos and maybe adding some mild information this year. The cabinet has a request for some significant changes. They've asked us to limit the report to 10 pages. This is currently a 40-something page document. They have also asked, come back and asked us to please remove most of the graphics. They would like primarily text. So over the, right, I know. So over the last 5 days, because this came in on Friday of last week and we're now at Thursday, Bonita and I have been working tirelessly to try to edit this report and meet some of their demands and requests. I shouldn't say demands. I should say we're trying to meet some of their requests. However, Bonita, you can comment, but maybe it's easier for me to say you all know Bonita has some restrictions as far as what she's allowed to comment on or not comment on. But I think that we have support from Bonita's bosses to continue with the report as we have it. However, for next year, we're going to have to make significant changes. What we've been able to do is decrease the document down to 27 pages, take out most of the graphics, and keep the bulk of it as text. Bonita, would you like to add anything to that?
The only thing I'd like to add is the fact that personally, I didn't think that you all needed to make it any shorter because it's your document. I basically said I was taking this back to you all and see what you said, what you could do. I think 27 is wonderful and very gracious of you all to do that. I don't see how it's going to go to 10 looking at the document unless a lot of stuff is cut out. And if you cut out a lot of stuff, you're hitting all those points that was the intent of the document to begin with. As Kari said, I'm restricted in how I can come further, other than I think it's very gracious that you all were able to go from the 40 pages to the 27. I am happy to tell them that this is your document and this is what we want published for this year and sent to the governor. So whatever you all decide in the end, I'll take it back, but I appreciate you doing it. I felt like it was a big ask, an extreme ask. As Kari said, there's when you change one chart in that document, you change all the formatting. You change where the verbiage goes. You change, it's just a very, I don't even know how to explain the document. It's a very intense, very detailed. I think Allie did a phenomenal job, but Allie's not here. So having Kari and I'd have to go back in and change it is a little bit difficult to do. Maybe it would have been, you know, quite easy for her, although I don't see how, because the formatting is the formatting. But again, I think you guys did a phenomenal job on this report. I thank you for being gracious enough to make the changes, but I think going in with the 27, as long as we proof it and make sure we made the typo stuffs that they requested. Some of the requests that they had, Kari, I don't know that, I know you and I haven't got to talk about it much, but some of the requests you can't change. They don't understand the content. So yes. It's kind of that thought process when you really don't understand it, you can't make those type of changes. So I left them. And when I send the email back, when I get your final document, I will make sure that I put that in the email. I have, as Kari said, I have discussed with my boss how to proceed, because it was kind of a hard hit when I heard that they wanted us to change it. She said, let for this year, the 40 pages, let it go, do as best you can, and then let it go. But moving forward, we would need to look at the 10 pages. I'm not sure how that's feasible, but that's a discussion for you all to have and to decide. And I will take back whatever you want me to. If you get it to 15 or 20 pages and that's the best that we can do, that's the best that we can do. And we will send it through that way. So don't get too bent out of shape because it, like I said, it's a great document. I think you guys have done a wonderful job, and I can't see how it can be done, but we'll do whatever you all want to do and we'll pursue it on. Do you all remember Elizabeth Cobb? Okay, she was with Kentucky Hospital Association. She is now my division director. So we do have her support, which is wonderful. And the question Kari talked about a moment ago with legislation, I'm actually going to start with Elizabeth because she understands. Instead of, usually I would go to Dr. White, which Dr. White does a phenomenal job and does understand, but Elizabeth has a little bit more grasp because she did work with STAR years ago. So I'm going to start there. And I think we can do that now. I think COVID is at a point, even though we are where we are right now, I think it's at a point where Elizabeth could start that conversation for us. So I'll keep you posted, but just wanted to remind you of that as well. Anything else?
Benita,
Yes.
I know Elizabeth. We were in Leadership Louisville in the Ignite program together.
Oh, cool.
She's phenomenal.
I am really thrilled. I tell you, the first time ever in meeting a boss, and I walked in and she said, "I know you," and I was like, I knew the name, but I didn't remember the face. And then when she said it, I was like, "Oh my gosh!" And then she started talking about you all and all of the stuff with SEQIP, and it was like, oh, wow, this is awesome.
Yeah, she's amazing.
Yeah, we're very fortunate. I'm thrilled that she's there, and I think she's going to be a great liaison. And when Kari said I have support, I do have support. So if you guys, whatever you guys decide to do, that's what we'll take back. So I don't want you to feel deflated, because I told Kari I felt deflated when I contacted her. I was very deflated. It was a hard concept for me. She kind of talked me down, so that's good. But moving forward, whatever you guys want to do with this, that's what we'll take forward, and know that we do have some support there. So,
hey, this is Lynn, just a 2 cents worth. I get this same thing with my leader because I'm often asked to put, how long have I been here? Since 2011, 9 years of work in a stroke program in 3 bullet points or on a 1-pager. Mm-hmm. And it always makes me sick at my stomach. And I have a headache when I'm trying to do it. But what I have to take away, and the lesson that I've learned over time with that, is what do I want them to hear me say? So I would agree with your statement as to do the best you can for this year because of all the formatting and changes and all of that. But for next year, I would, if you want them to read it, if you really want them to read it and hear what we are saying, you need to go for 10 pages. I'm just saying that, and I bet Bill could probably say the same thing. Executive directors and leaders and boards don't want to read through all that. They want the down and dirty. What do we want them to hear? So come up with a summary paragraph of the history of the work, and then give them the things you want them to hear, the main points, and kind of think of that for next year to get into 10 pages, because I love this report because it falls right into me wanting to tell the whole story and all the history. Nobody else wants to read all that, and they won't read it. I'm just telling you, if you want to make an impact, it has to be short and succinct. And I've learned that the hard way, being deflated and beat up over the last 9 years to try to keep doing that, to explain why I have my readmissions are the lowest in the system. Things like that. I'm like, because I have a stroke program, that's why. And then to try to put that, well, what are the main things you've done to make that happen? Well, because I have a stroke program. And then like people that don't do this work don't get it. So you have to figure out how to make them get it, and how to put what you want them to get in a very short and succinct story that they'll take bullet points away from. So just my 2 cents.
thanks, Lynn.
So definitely agree. So hence the rationale to try to meet them halfway and try to reduce the report at least in half for this year. So as we didn't just come back and say, sorry, we can't do it. Now, this is not a final document. I just wanted to show you sort of conceptually what we're talking about. So without like taking hours and weeks to rework the whole thing, which we don't have, we kept the background pretty much the way it was. We modified the chart a little bit so that it would be smaller and wouldn't take up a whole page itself and would like continue on to the next page. Here's where you're going to start seeing all the graphs. So if you'll recall, we had like pie charts and trend lines and basically showing that things hadn't changed over time. We took all of that out and made it all text based on the recommendations. And then instead of having any type of communication regarding the risk factors, we just simply put the chart so that people can see in our work and in our patient population what the risk factors were. Again, over here, you'll see we kept the definitions, the arrival mode, NIH. We kept this because it was not hard to leave in and it fit at the bottom of the page and it would have just been a gap. So again, our Get With the Guidelines performance measures. And I think moving forward, we may choose to just put our results in a chart such as this instead of each one individually. But for now, we've kept it looking pretty much the way it was and just taken out duplicate charts. They did not ask us to remove this chart, but they asked us to remove the charts that were sort of explaining and further clarifying the data. So that's what we've done. And basically for every measure so that they can see the evolution over time as it was. And then you see me just scrolling through this is looking at the strategic map. This is also potentially another option for keeping it 10 pages. You know, it's sort of succinct. This is where we're at. This is, you know, provide some background. So we will be, if you'll think about it, Lynn's insight is certainly spot on. If you'll think about it, this document will be sent to the steering committee for review to get your feedback on things that you think maybe could be cut out to help drill it down a little bit more. And then as Bonita indicated, you know, we will migrate to more of an executive summary next year, limiting it to 10 pages. The other thought is, if you all are using that large report that has sort of been built on every year, another thing is we could keep that document internally for the hospitals, generate that, and then submit an executive summary synopsis of the entire report to the cabinet and the governor for review, instead of incorporating like the executive summary in the larger document, pull it out, send that in, and have both so that everyone sort of can get what they need out of it. So think about it, and we'll move forward next year to meet the objectives of the request. All right, let me get this PowerPoint back up. All right. Okay. And a big thank you to Harold of the UK Norton Stroke Care Network. So this is where we currently stand as of August with our current stroke centers by county in Kentucky, as well as you can also see the volumes that are surrounding us by state. Our stroke volumes. So the data that you see, the data that you're going to be seeing here is run within the last 2 weeks, so pretty accurate as far as what we have entered into Get With the Guidelines so far. By 2019, you know, you can see our volumes have increased every year as far as the number of patients that we are capturing in our registry. And at last check, you know, 75% of stroke patients in our state are captured through this data in some format. Of course, it is still to be determined. We're up over 6,000 cases entered at this point, but what that's going to look like and how COVID impacted all of that, whether it's due to patients arriving to the hospital or not coming to the hospital, or we had some limitations in our data abstraction and maybe some changes at hospitals on the way the data was abstracted due to resources. So to be determined how that is going to look. When we look at the breakdown, as far as by diagnosis, we're meeting pretty much or consistent with the national guidelines or numbers, if you will, for stroke volume. 80% of ischemic strokes, 10% intracerebral hemorrhage, 3% subarachnoid, 7% TIAs. And then the others, no stroke related diagnosis or blank or missing, stroke not otherwise specified. And these, are all less than 1% of the data. So at least I think we're capturing, the diagnoses that we need to capture for the most part. So what about age? Historically, we've all noticed that our patient population is really younger. And I think that's reflected here when you see the mean age versus the median age for this calendar year. And we do have a population of folks here, 10% over age 85, then 66 to 85. So you take this bucket, and this is of course where we say, well, everybody over age 65, the risk goes way up. The older you get, the greater the risk of you're having, yourself a stroke. But we still have 41% of our patients under the age of 65. So that's, to me, and I think all of us would agree, a younger patient population, even though that number is increasing nationally. Most systems, when they look at it, the age of their stroke patient population, there is a shift of younger patients on the rise. But in Kentucky, we've sort of seen that for some time now. That's not really a new shift for us. Equally distributed between males and females has been this way for years, about a 50-50 split. As far as race, of course, our state predominantly Caucasian population. So whites make up the bulk of our patients. So when you say, okay, well, is it generalizable? Maybe not, because most of our patients entered into our registry are white, 10% Black or African American. And then we have the other category broken down over here, unable to determine, 1.5%, Hispanic at about 1%, and then Asian population. So for Kentucky, it predominantly Caucasian or whites with Black or African American and 1% Hispanic. So what about our arrival mode? So this is something that I know Bill called our attention to, a while back, sort of saying, hey, we kind of noticed that we're having a dip in the people arriving by ambulance, and what does that look like? So if you look at just the last 5 years, so as though it didn't get, or 6 years, so that it didn't get too overwhelming as far as, the bar graphs and can you make sense of it. So this is data from 2015 through to 2020. And of the red, it is sequential by year with the colors. So we're not budging a lot. And over here, you can see as far as how our patients arriving by percentage. So since 2015, around 40%, in 2020, 40%. And in 2018, it had dipped down just a little bit. When you come over and look at, well, how many people are bringing themselves to the hospital, which I'm sure everybody's looking at this at an individual hospital level as well. Again, it has stayed really pretty much the same at around 30%. So we've got 40% coming by EMS. We have 30% bringing themselves. And then when we look at our transfers in from one hospital to another, the other 30%. So the bulk of our patients, it's a 40, 30, 30, really on how they're getting to our hospitals. So what about pre-notification? Well, we know that this data is really limited. It's limited by the fact of all the things we've discussed in the past, as far as if it's not documented in the run sheet. And in the past, we were having trouble getting the run sheets consistently at all hospitals. A lot of those infrastructure or abstraction processes have improved, and we're getting greater access to the run sheets now. So, is this still a reliable number as far as documentation? If it's not documentation on the run sheet, we have a hard time at the hospital level, with who's responsible for documenting that, where is it documented? So that's inconsistent. So, but based on the data that we do have, this number is, of course, making significant, I think, changes from our baseline to where we're at, 12 years later. And I hope that we'll continue to see this number continue to go up as we do continue to improve the processes pre-hospital, as well as in our own hospitals. And this is looking at what does it look like for us compared to all hospitals, and get with the guidelines, all Kentucky hospitals, and then Kentucky SEQIP hospitals. And, you know, as this matures over the years, most of the Kentucky hospitals are the SEQIP hospitals. So I think that's why we have a few who are collecting data that are not, their information is not into the SEQIP data set. But, you know, we are improving ourselves. If you look, you know, we're not doing as well as I think we could be. But I think if you look at the red bars are, of course, all hospitals are at 60%. We're at 55%. It's a challenge for everybody, it seems, but we are making improvements. And I think that that is encouraging. NIH stroke scale reported. So as this became a measure and was being tracked, you know, this as well has certainly improved over time. And we're capturing this information according to the metric requirements 97% of the time. And that's been pretty much sustainable for the last 4 to 5 years. What about VTE prophylaxis? Again, this is a measure that our hospitals are really excelling at. For the most part, I'm sure there's a few glitches here and there. Processes change at hospitals, central supply changes, whatever there, you know, that there is that changes if you need SCDs or whatnot, or as we're moving more towards chemical prophylaxis, maybe that's making it easier because we're not relying on, you know, physically going to get a pump plus SCDs, et cetera. But again, we see good work being done here that is also being sustained. The dysphagia screen, a lot of effort and time and energy went in to this effort in the first 5 years by all of the hospitals sharing best practices, because, you know, this is still a challenge for various reasons, right? It might just get missed in the ER. A lot of times it's done, but it doesn't get documented. The time of the swallow screen, maybe after the time on the MAR of the first oral intake. I know that it's also common, not just at, I won't say common, but some of our fallouts, it's not just at our center, but at other centers. If you have an intubated patient and the route is ordered PO and the nurse signs off on the MAR, they even gave it through the tube. This is not just a concern locally. This, you know, I've heard this at national conferences, et cetera, and I'm sure you have too. We're not alone in those type of fallouts. So we have work here, but you know, again, over a 30% improvement over the last 10 to 12 years. Early antithrombotics has been a success story from the start. We are exceeding over 90% since 2008. So getting our patients antithrombotics by the end of hospital day 2 is certainly something that we are successful at. Anticoagulation for Afib is also something that all of our hospitals really perform well at, and really over 90%, except for 2010 when it was slightly under. So strong work here as well. What about antithrombotics at discharge? Well, I don't know. We're almost perfect, at least according to the way the data set is entered. And if we round it up, it would be 100%, which would not be accurate, but it sounds really nice, doesn't it? That we're 100% in something. We're very close. What about the LDL? So lipid panels, doing a lipid panel, you know, that has improved over the years. The evidence has evolved and continues to be strong in the cardiac literature of how important it is, high dose statins, et cetera. We're right at 96% on this in 2020. So again, consistent over the last 6 to 7 years in this as well. What about intensive statin therapy? So that has matured over time. I think the cardiac literature, this has been known for some time, that intensive statin therapy, how low can you go on the LDL is too low. You know, is there a too low? And when you talk with the cardiologist or the primary prevention or secondary prevention, somebody that has atherosclerotic, high atherosclerotic risk burden, or for secondary stroke prevention in their field, of course, there's no low too low. Single digits is fine on LDLs, and there's no evidence for bleeding. In the neurology community, of course, we get a little more scared because we're the ones that are taking care of the hemorrhagic strokes, and we're seeing those patients. So when they start talking about, well, how low can you drive the LDL, some people start to get a little squirmish. You know, when we start dropping it less than 30, you know, there's concern. And if the LDL, let's say your stroke patient comes in and the LDL is 78, you know, what's the case for putting the patient on high dose statins? Well, actually, it's pretty good. It's actually very good. But again, in the neurology field, there's outside of, I would say, vascular neurologists, there's been some concern on this, but our numbers are bearing out that over time, people are coming on board with the concept and seeing good outcomes. Smoking cessation, again, high performers in this area. Stroke education, meeting all of those metrics as far as what the patient has to be educated on is also performing well, 96%. And then rehabilitation considered. I mean, again, I think all of us have this pretty much hardwired into our programs as far as incorporating our rehab specialists to perform assessments, and we see the fruition of those efforts. So what about the thrombolytic therapy? Arrive by 2, treat by 3. So recall back here, 2008 to 2012, we said, geez, and especially here for those that have been participating across the board for all these years, we're like, gosh, this looks really bad. Only 50% of eligible patients are being treated within, arrive by 2, treat by 3. And at this time, we also had some hospitals that had not adopted the 3 to 4.5 hour time window as far as administration of thrombolytic therapy. They're still waiting on that. And that, you'll recall, in 2009 is when the AHA came out with their position statement saying that this is evidence-based and it's really recommended, even though FDA approval for the expanded time window had not been sought and still is not. It hadn't been sought. It was in the process. It was sought later, and then not present because of the lack of 2 clinical trials, with one of them being in the United States. But a lot of effort went into this, looking at documentation as far as potentially the reason for that. And you see over time why, with all of the efforts at all of the hospitals and decreasing door-to-needle times, et cetera, we are now at 95% of eligible patients that arrive by 2 hours being treated by 3. And of course, this is the Joint Commission standard metric, but then AHA has, now changed as far as their award status or achievement measure is now arrive by 3.5 and treat by 4.5. Now, this is impressive. Out of all the slides, this was like, this is so exceptional by everybody on the team, in the state, contributing your data. My gosh, look at this. From 2009, when it was recommended at a little over 30%, we're now up to 93, I'll say 94% of our patients who arrive within 3.5 hours eligible being treated by 4.5 hours. And this led me to call Amy yesterday and say, Amy, I don't care that you're leaving the American Heart Association. Here's the something I need you to get done by close of business tomorrow. A national change to the way Get With The Guidelines gives awards. I said, I think they should be giving awards for stroke systems of care in a state, because this is phenomenal. It's one thing for a hospital or even a hospital system in the same system to be able to get processes that support data like this. It's a whole other thing for a state to commit to it and improve all of their processes and generate data like this. So everybody flood Amy with an email today, giving her the requirement that this has to be carried forward by tomorrow at 4 p.m. And then if it doesn't happen, flood Abby.
I was going to say, see Abby.
Flood Abby by Monday morning at 7 a.m. So anyway, strong work, you guys, really strong, proud of this, very proud of this. What about our time to thrombolytic therapy? So I also included here, you'll see down at the bottom, the numerators and the denominators, because that's always something I want to know. Well, yeah, you got 85%, but are we talking about 10 patients, or are we talking about 500 patients? Or if you got 20%, again, are we talking about 10 patients, or are we talking about 500 patients? So looking here, comparative, you'll see all hospitals to Kentucky SEQIP hospitals, 85% for all hospitals, really to 89% for door-to-needle time less than 60 minutes. So again, we're looking at these target stroke 3 or these metric goals and as a system. And some of them were pretty darn close to getting the entire award status. So what about the door-to-needle time of 45 minutes? We're we're getting there as far as the goal of 75% of our patients being treated. Again, 61%, all hospitals, 68%. So we're getting there. We're getting there. And then what about 30 minutes? Boy, we're getting there, 35%. So we have seen great progression in utilization of Alteplase, and we've also seen exceptional work being done as a state on decreasing the door-to-needle time. So very strong work. This is from 2008 to 2009 through 2018 data, where you can see pre-target stroke phase 1, phase 2, and the decrease of door-to-needle times, pre-target stroke for 108 minutes mean to 51.9 minutes in phase 2. And when we looked at our outcomes from 2009 to 2018, looking at percentage of patients receiving thrombolytic therapy, we went from about 4.5% up to 9%. So that doubled. Not eligible patients, but as far as total rate of ischemic stroke patients that are getting thrombolytic therapy doubled in 10 years in our state. Looking at the arrive by 2, treat by 3, up from 60 to 89%, arrive by 3.5, treat by 4.5, 30, you saw to 66%. And then the data I just showed you is even much better. So what we've been able to achieve in the last 2 years, that work has continued to advance. And then in hospital mortality, significantly decreased in this thrombolytic therapy group, as well as discharge disposition home and being able to walk independently also went up significantly in the thrombolytic therapy group. As you know, we struggle to collect modified Rankin data as far as outcomes work, just because that's very difficult to get from all of our hospitals submitting data to get with the guidelines. But when we look at where patients were discharged and compare ourselves to all hospitals, what I look at is home, SEQIP, 49%, all get with the guidelines, 49 to 50%. And then I always look at it like as if you're thinking about good outcomes, home and to acute rehab, 16%, 20%. So we're around, 50, 66% of people with, I would say, just a rudimentary great outcome if you're going home or to acute rehab. And then the mortality rate here is less than, or right at about 10%. Expired is 6%. And then I also include anybody that went to hospice when I think of a mortality rate, just because of, if you're in hospice care, of course, then your life expectancy is short. This chart, I think, is very useful in looking at how we've performed over time with the stroke measures. It was something that we were able to share at the International Stroke Conference this year in a poster presentation. And here you see that poster that was presented at the International Stroke Conference. And then also looking at being able to drill down our door-to-needle times with, the statewide collaboration over 10 years, oral abstract presented this year at the International Stroke Conference. So our in-hospital mortality, where are we at as far as this year? So for all stroke types, 6%, 3.3%, and then you can see the year prior, since this is only year-to-date data as far as cases that had been entered, subarachnoid hemorrhage, intracerebral hemorrhage, and then fortunately, not anything significant here. So the question is, with COVID and a report, certainly in the heart of the pandemic and the scare, especially with everything going on in the Northeast, I think, where you saw as far as the nightmare situations that were occurring with the overburden of the hospitals, as far as patients, and also just the scare of, if I go to the hospital, am I going to get this? We saw a significant reduction nationally in patients presenting to the hospital for heart attack or for stroke. And I know some of us felt this at our hospitals in our state more than others, as far as looking at, well, maybe people came to the hospital, but maybe they waited longer. Are our TPA cases going to go down? Are the severity of the strokes going to go up? And I know some of our hospitals have been looking at this data So I just thought it was interesting. Well, let's pull ours and see what does it sort of look like based on what we have so far, with the assumption that the first 2 quarters of data have pretty much probably been entered, at least through May, I would say. We can feel pretty comfortable, but most of that data has been entered. And here you have it broken down from the last known well to arrival times. And you see, I just go, if you look, there's not a whole lot of change early on as far as, patients presenting within that 120 minutes, up to 150 minutes. All of this percentage-wise is staying about the same, up to 210 minutes. And then when you get out here, like the excess, like I waited forever to come in for my stroke. Here is the only thing I see where it's gone from 18% up to 25%. So like maybe I wanted to come, but I waited, and this year I'm really going to wait until I'm sure I have to come. I don't know that we can make that level of inference, but just so you can sort of see as a state what has happened with presentation from last known well to arrival is sort of where we're at. And then if you look at the median time, which is probably telling, 279 minutes. Here's where the tell is, I think. Okay, here's where the tell. So if you just look at it like this, not so bad, but you look at it like this, went from 308 minutes to 355 this year so far. What about symptom discovery to IV Alteplase on an inpatient? So this is something we haven't looked at before, but it's interesting. So I'll toss this out there as maybe something we might want to consider looking at. If you look at our data, over here, this is just SEQIP hospitals, and here you'll see the numerator, and here you'll see the denominator. So this year's been particularly challenging. Again, it's very low numbers. It's low numbers, but our door to needle times on our inpatient strokes are certainly not likely where we would want them to be. If you come over and look at this graph, this is all hospitals compared to Kentucky SEQIP hospitals. And this year has been, I don't know if we're not capturing the patients, the inpatient strokes. That may be something. That may be why, this is a change. I'm not sure. But anyways, it's interesting. I just throw it out there as food for thought. And your comments here in just a few minutes. What about door in, door out? So Bill and Sasha will be talking about this later on. So I'm not going to say a whole lot regarding this, except for, looking at, and again, I included the numerator denominator from 2018 to 2020 based on cases that are in the database currently. And as far as meeting the 90-minute threshold, certainly we have work to do, and it's particularly a challenge for multiple variables that Dr. Zamet mentioned, and then of course that all of you are aware of at your hospitals and your referral sites. So let's just take a glance. So if you run your STK outpatient reports and look at your own individual hospital, you get things like this. If you want to compare yourself to others, you can, or if you want to look at how your trends have occurred over time. So this, the 1A metric is all stroke patients, door in, door out, 2019 to 2020 down here at the bottom, and you see the time. So 60 minutes, 90 minutes, 120, and down here on the bottom is the minutes compared to the percent of patients that you're getting out within the time period. So I think if we just draw the line right here, everybody's goal is here or here, but regardless of the year, we see that we do have work to be done here. Well, what if we look at just our hemorrhagic stroke patients? Again, the red is 2019, the blue is 2020. Not that we can draw any types of conclusions for this, but I think you can again sort of see we have work. Looking at the TPA group, drip and ship patients, this does sort of come over further. So if the patient's getting Alteplase, it looks like our transfer out times are better than they are maybe for others. And then Also looking at if they did not get Alteplase, but they're suspected to be an ELVO candidate or eligible for mechanical thrombectomy. Again, you can see here where we're at with the data that we have entered. And then looking at no IV Alteplase and no suspected ELVO, which goes to everybody's point when they say, you know, these are not apples to apples, these patients, right? Like the emergency of getting somebody to another tertiary center is variable based on their immediate needs and potential time saving treatments, life-saving treatments, disabling saving treatments. So this is just what we have. If you wanted to then say, okay, well, what does it look like if we say drip and ship compared to IV Alteplase that is mechanical thrombectomy eligible versus no Alteplase and mechanical thrombectomy eligible? You know, this is our data as far as what we have that we can see right now that we can, you know, potentially use as our baseline data, as all the efforts really have just now started in the last 6 to 12 months. And there's been a bit of a stopgap there, I'm sure, related to COVID. Now, we talked about this earlier, but this has not fallen off of the radar. It is still a goal to get the data from the Overreact campaign, looking at arrival mode, Alteplase utilization by zip code analysis and outcomes. This is also something that I hope, because this is like targeted therapy. You know, when they talk about cancer patients and they talk about targeted therapy, right? Like how can you make your interventions better and get the best bang for the buck for the people who really need it? So this is geographical information system mapping by county, which we can hope to try to get back into with some of our data, using that with our Get With the Guidelines data to be able to understand where are the biggest gaps in the knowledge and related to which topic, so that we then focus our efforts there to improve care in that county or community. Remember, we can go down to the zip code and we can also look at it by county level. So this is also still on the radar. It's just a matter of figuring out how do we do it. We will certainly need an epidemiologist's help. We can't do it without one. And then as Lacey discussed earlier, the pre-hospital assessment for detecting stroke or ELVO is a major initiative that we will be working on over the next 6 to 12 months to improve processes, collect data, and then hopefully be able to have a model for other healthcare systems as well as regions in our state to begin expanding this outward. So with that, I'll stop, entertain any feedback, questions or comments. And as I say, on a lot of these projects in the subcommittees, you'll be hearing more information about them and have opportunity to contribute information there as well. So thank you.
Kari, I was just thinking those SDK outpatient data reports, those might be good to like isolate when we start tracking even for the Louisville Stroke Systems of Care pilot, and using those data maps and presenting that to EMS too, especially when we start working with ground EMS. And maybe even with Kentucky Board of EMS, sharing that with the Heart and Stroke Subcommittee, Lacey, with Dr. Frazier. I mean, those might be impactful to share that information.
Yeah. Good idea. Thank you. Yeah, agree.
Say, Amy, this is Bill. Can you hear me?
Yes, sir. Yes, sir.
Okay. Sometimes I get confused on our goals. The standards or the guidelines for door in, door out are less than 120 minutes. The Get With the Guideline goal is less than or equal to 90 minutes. Is that correct?
Yes.
There we go. Yeah, Joint Commission has the 120 minutes, and in the reports that we have that Get With the Guidelines generates, it has it as 90.
All right, thank you.
And I do think, Bill, you know, like I know Lynn has pointed out a million times, as others have too, you know, 120 minutes for the patient that's not mechanical thrombectomy eligible, not a hemorrhagic stroke, not an IVTPA patient that came in 3 days from their stroke, and it just presents to a hospital that doesn't keep stroke patients, that door in, door out time is completely different than the patient that arrived, you know, 1 hour from their intracerebral hemorrhage compared to the patient that's a drip and ship compared to the patient that has an ELVO. And so, you know, I think that that will sort of tease itself out over time, but unfortunately, they've all been dropped into the same bucket.
Yeah, I absolutely agree. What I don't want to do is confuse what our goals are for SEQIP versus what our goals are for get with the guidelines versus Joint Commission. And give me some time to think about that, and we'll talk a little bit about that more in our DiDo update later on today. Obviously, we want the patient to go as quickly as possible, safely and quickly as possible, but I also don't want to set us up to fail if, you know, so.
Yeah, it's just to confuse things more. Again, you know, my pain at working through the DNV standards, it says when medically stable, they haven't like hardlined a goal. So, and as my neurosurgeons, we fuss back and forth with them about why is it taking you so long? That's one thing they say. Yes, we know that they need them to get out of the ED faster, but we can't put a patient that's neurologically unstable in a helicopter either. So it's not just boom, send them, send them, send them. There's more that goes into it than that. And I think the 90 minutes and the push is people are thinking about those people that need thrombectomy. Mm-hmm. So when I do my team meetings and I show them that data and they look at those really long times for things like hemorrhages or the patient that was no ELVO, no TPA, I'm like, I really don't even want you to look at those numbers. I want you to look at this one. Mm-hmm. So I hammer them on the thrombectomy people, and I tell them, if we see this line going down, that's really what all I care about, because these other ones are left up for debate as to why they didn't get out the door so quickly. Because you don't want to just say, we have to meet a goal, we have to meet a goal, and forget about patient safety. So anyway, again, sorry, just my 2 cents worth.
This is Abby. One more comment, I know a lot of people do look at that first graph that comes out of STK-OP1, but really I don't even think that's what's officially reported, because that does lump everybody together. So looking at those sub graphs that tease it out by those populations is really where you're going to get the most useful information. So just keep that in mind.
Anybody else? Questions, comments? Okay, very good. I think now is the break for lunch, and we start back at.
Correct, 1 o'clock. So yeah, we actually, sorry y'all. It's 12:08 right now. We're a few minutes early, so we'll go ahead. We'll break for lunch until 1 o'clock. If you guys have any questions that you think of, have them ready when we come back. You can put them in the chat box over anything that we've gone over. And at 1 o'clock, we are going to start our subcommittee chair updates. Sorry, swallowed wrong.
Amy, do you just want me to do my update then?
Oh, I'm sorry, Abby.
That's okay. We can do that. No, you're fine.
No,
I'll just do it during the subcommittee. No, I thought people are already ready to break. You gave them the go ahead.
I apologize, Abby.
That's right.
I'm sorry.
It'll be short, and I'll just do it with the subcommittee. No problem.
Okay. All right, guys. So we'll come back at 1 o'clock. Enjoy your lunch, get caught up in whatever you need, and then we'll see you back then.
Great. Don't forget to stop the recording, Aim.